Thank you, Bernadette. Hello, everyone. Sorry I couldn't be there in person today. But first of all, you know, as I'm coming to you online, I know there are many people also online. So in the spirit of reconciliation, I'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. I pay my respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I also pay my respects to the veterans and their families. So Bernadette asked me to talk about a particular evaluation that I've just completed for Department of Veteran Affairs. It's called the Wellbeing and Support Program, or the WASP program for short. And I'll tell you a little bit more about that. I'll step through what we found, how we did it, etc. But first of all, I'd like to acknowledge my colleagues who supported me in doing the grant and the process, particularly Associate Professor Billy Cambois, who helped me do all of the health economics cost analysis, and particularly Jeremy Stevenson, who supported me pull everything together. DVA, and particularly the DVA WASP team, this was a more than two year project, and we were walking alongside each other at each step in the process. The veterans, of course, that I spoke to and their family members, and the many case managers who inspired me through the conversations that I had with them. So what I'll talk about today, I'll give you a bit of the context, and I'll talk briefly, because this was a very large evaluation with a number of parts to it. I haven't got time to cover everything today. I understand DVA are looking at putting the reports and progress reports online so that people, particularly the qualitative results, that people can have a look at those in more detail. I'll talk a bit about particularly the wellbeing measures and what we found from all of that, and a brief demonstration with a case near the end. So I'm assuming that some people in the audience won't have heard what the WASP program is. It commenced in late 2018 and is still currently, it is still going. DVA are hoping that it will be continued on, and are certainly making efforts in that direction. But it is actually still operational. So it's on a holistic community case management service model for veterans with significant complex physical health and or mental health needs. So this is the group of veterans who are absolutely known right at the very top of that triangle to have multi-morbid issues, psychosocial complexity, very significant issues because of their service related to physical injury, mental health injury, often medically discharged, but also included people who've been administratively discharged for a range of reasons. It included people who had recently transitioned and were transitioning, but also people who'd been out of defence for a very long time. I think the longest was almost 40 years. So it was a full range of people. In fact, it captured many of the people that were probably the least likely to trust and engage with DVA. So a particularly interesting group. It's a significant milestone for DVA, an incredible cultural process that I witnessed going on. So when the program first set out, the idea was to have these these three types of veteran groups that the DVA identified. And I know this is a busy slide, but they had a sense that there was this enhanced mental health support cohort. So people with severe complex mental health needs, high risk of suicide, drug, alcohol misuse, likely to have lengthy admissions, frequent admissions to mental health services. And then there was this complex care needs group, people that they said had complex relationships with DVA, personality disturbance. You get a sense of the language of the early documentation. And I should note that this changed over the course of the 2 years, which was quite interesting as well. Then the third group was a supported transition group. So really wanting at least half of the 200 or so people that were earmarked to try and come into this pilot to be people in the earliest stages of transition from the ADF, to try and get early intervention going for a known cohort with complexity. On the right-hand side, these are just the various parts of within the DVA system where referrals were likely to be coming from within DVA. So an early pictorial of what the case management model would look like was that there would be referral, there'd be an initial contact, there'd be an initial assessment, there'd be development of a plan, implementation, review, and then exit. I can safely tell you that the actuality of the 2 years was vastly much more nuanced and layered and complex than that. What the DVA WASP team very quickly learned, and remember I'm sitting alongside this doing a process evaluation. So this is a service that was essentially set up from scratch. It felt that way, and learning as people went along. So there were many aspects of referral, the initial contact, the assessment process, how much, how little, who should do that, what elements are more or less important. And so there's a whole learning throughout the process. And part of the report was actually around the process evaluation, and I'll talk to that a little bit more in a minute. So the idea of these case managers and their role, absolutely fundamentally very early, recognition that their primary role was to establish trust and rapport with this veteran group. There was a clear understanding that many of these veterans had just simply disengaged from DVA, many for months, years, disengaged from services. So the role of the case manager was very much about building that trust again, identifying the needs and aspirations and goals, but recognising that many of these veterans, where they were currently, were not in a headspace to even set goals in the sense that they had experienced perhaps with the rehab services. So developing people's hope for change was certainly part of the case manager's role. All of the usual things around trauma-informed, trying to broaden things out beyond the limited set of supports that could be possible for veterans, and shifting the pathology view to one of building resilience, building strengths, really trying to get the veteran's view of things. in a real practical sense. Of course, what it also meant was that they were giving the permission to the case managers to actually do work in ways that hadn't been the norm. So actually doing face-to-face as a regular, you know, going to the front door, being inside the house, bringing the veteran outside with them, going along, you know, walking alongside, not just being on the end of a phone. So really significant shift. The role of the partners was something across the pilot that I didn't have the opportunity to see as much of as I would have liked. I think the case managers were still learning themselves how to fully involve the partners. And a whole lot of liaison with GP specialists, so really being a linchpin of communication. So plugging all those gaps, being the glue, basically, of a case management role. They also had very intensive input from the DVA WASP team quite early on, and throughout certainly the first 6 months or more, with regular contact, monthly case conferencing, many people in the room. So all of that was a learning. So the evaluation questions were very much following what you're familiar with, I'm sure, is a realist evaluation. So we asked, you know, did the pilot improve coordination communication of these veterans? Did the experience for families improve? Did perceived wellbeing and psychological distress decrease as reported by the veterans? Did the pilot improve accountability by services and improve engagement? And did the pilot improve access and uptake of DVA offered and other community services? So certainly the first, the third and the fifth one of these, absolutely a resounding yes was what I found. The second one around families is still unsure because we didn't hear from a lot of families, which was disappointing. Likewise, not a lot of service providers like GPs, psychiatrists, etc. Came forward for interviews and contact. So the evaluation methods were mixed methods. As I said, it was a process and an outcome evaluation, a whole lot of interviews, focus groups, surveys. We had a plan of how we would, aim for. This was a very moving, shifting process, absolutely, really driven by the veterans. And, you know, that's a good thing, so that we didn't impose methods that were not going to work at accessing and reaching this population. We also had a set of predetermined wellbeing measures, which were agreed with DVA. The Personal Wellbeing Index is one of those, the WHODAS, which is a measure of disability, the K10, which is a measure of distress, and the Dimensions of Anger. And one of the earlier speakers today commented on the issue of measuring anger. I'll talk to those a little bit more and show you in a minute. The other analysis, because our best laid plans were changing and very fluid as we went along. So really we were looking for all and any data that was of value to the evaluation. We certainly collected a whole lot of demographic information and de-identified demographic information was available to us so that we could actually do some analysis of a whole range of moderating variables, such as pain and drug use, etc. And then, of course, the health utilisation and cost analysis that we did, which again was limited to the data that we had available to us from within DVA. So these are the actual, a little bit of information about the scales, and I'm sure you're all quite familiar with them. You can see that there are a very limited number of questions. We were very conscious of the burden for veterans and their families. For the veterans, we asked the 4 measures. For families, in particular, we asked the Personal Wellbeing Index. So the important thing with these, I think, is to see the issues around the cut-off scores. And I'll talk to you a little bit more about that and show you in the results. So for a realist evaluation, I'm sure you're familiar, we asked, is it working? If so, why is it working? What's not working? How could it be improved? For whom and under what circumstances? And we did a whole process evaluation by using interviews with veterans, with case managers, and also with the DVA WASP team, because they were actually part of the process of implementation. So those 3 aspects together gave us a very rich data on the process of actually rolling out this pilot service. And overarching the evaluation was what's known as the RE-AIM framework. So through that rich qualitative data, we were able to see the reach, the effectiveness, the extent to which the program was adopted, and was it being delivered as intended? What were all the nuances that people were finding were enabling them, that they were having hurdles put in front of them, etc., etc. So it gave us a very rich qualitative experience that we could talk to, which I don't have time to talk to fully today. So as I said, in this pilot there were just over 200 veterans that were variously brought into the pilot over the course of the 2 years. From those sample of people, we went through the case managers to ask for consent for people to undertake interviews or conduct brief interview surveys with them. We had a small number of interviews across really all of the veteran and family in particular, as you can see by these figures. We tried very hard. The case managers had very good contact, but of course it's always very difficult when they're dealing with very complex needs, often people in crisis. To give you a sense of this program, often it would take sometimes 2-3 months, even for the DVA WASP team to engage the person in the consent process to enter the pilot. And then for the case managers, it would be sometimes 1, 2, 3 months and an ongoing process of maintaining rapport and trust with the person. So this was quite a unique program. So the experience of leaving the ADF, what What was resoundingly the case from the interviews with the veterans, the sense that we got was that there was incredibly limited inclusion in the planning and decision-making of practical support to navigate the transition for the veteran. Many of the veterans that I spoke with in interviews described a situation where even though they'd had perhaps, weeks, sometimes months of a known injury, and knowing that discharge was coming, there was very little in the way of actual planning before they left. And some people described just receiving, here's the paperwork, and the next day it was going to be the day that they were leaving. The other thing about this particular group was that, strikingly, they were managed administratively and given, all of the paperwork, presumably, but it was a time when they had the least ability to actually comprehend, read, etc., this paperwork. So a number, for example, in these brief interviews which we developed, it was obvious from actually just looking at the handwriting and the shakiness of the handwriting of these people that they couldn't even easily fill in a brief questionnaire that was a like-it-rated questionnaire largely. So it's a significant, it's a flippant thing, but it's significant that these people are being asked to do things at the very time when they had the least ability to do so. So little wonder then that perhaps they felt that they were ill-prepared for transition. They were just simply overwhelmed at the time. So the WASP case management pilot was something that was really going to fill that gap. I'll only share these two qualitative quotes with you. I think they typify the many hundreds and hundreds of quotes that I could have presented. But what really struck me was Ben, for example, who said, without this case manager support, I would be stuck inside my house, self-destructing, which I've been doing for the past 2 years. And many of these people had no linkage, no support. They weren't linked with GPs. Some of them, they certainly weren't linked with specialists, many of them. They were just disengaged. And this is not the first person that said, I would have topped myself by now, if not for him. And even more striking, I think, because of the cultural shift that I was observing in the team. And, admittedly, the language is not, not great as far as saying people are damaged. But this is from a senior DVA WASP member, and I think it's astounding that he says, I think they're sicker and have more damage than we ever understood. I can't believe these people were in such a state. Well, they're just not coping in any dimension or scale. You can't push them. So you can see his understanding absolutely fundamentally that everything that in the way that they were delivering things currently was just not working. You've got to let them find their own pace and work with their providers. So all of this coming from a strengths perspective. And I'm not surprised we have levels of suicidality. So this was like an absolute light bulb moment. So on the measures, so you can imagine this was a very challenging evaluation to do to actually get the data. Because, you know, we could set out at the start and say, well, we'd like the case managers to do these wellbeing measures every 3 months or every 6 months. Didn't happen, basically. And, you know, very quickly we realised that it was going to be good if we got any measures, and certainly if we got a pre-measure and a post-measure. So, of course, all of the quantitative analysis methods had to change as well. So what this table shows you is that out of those 204 veterans, we had 125 that had done one set of measures, at least at baseline. And then we had a far lesser number who'd done an early measure and a late measure. So for the people who are stats people in the room, you'll appreciate our dilemmas that we had because we wanted to build as much rigour into this evaluation as we could. So the 73 that actually had a pre and post measure, of course, begs the question, what about the, you know, other 131? What was life like for them? The ones that we didn't hear from. So this slide shows you, gives you an indication of the baseline measure for that, that group that we had at least one measure of all of these 4 wellbeing measures. And it gives you the mean and the standard deviation for this particular veteran cohort. So no surprises. What these findings tell us are absolutely this was a group with very, very complex needs. When you look at the personal wellbeing index, you know, the normative range is between 70 and 80 out of 100. The mean for this group was just under 35. And some were in the 20s, as you can see from the standard deviation. So a very long way from normative. And again, repeated through all of these measures, the K10 in the upper range in the 40s. These are people that you would normally see in crisis, in inpatient mental health. And yet they're sitting out isolated often inside their houses, not receiving any support. So little wonder this is a very, very significant group for suicide risk. The dimensions of anger was, I think, less than the DVA thought. And it's interesting, there's one question in this particular 5-question survey where the person is asked whether they got so angry that they would hit someone. And that's the one that they rated less. They, despite the complexity, they prided themselves on their ability for self-control. So this pre-post analysis, what we're aiming to do, we used a linear mixed model process. Given the variations in every single veteran, we didn't have nice, neat timeframes. So we had to use this approach to still have a rigour in what we were doing. There were so few participants that had 3 or more, it just would make it not meaningful. The average time between baseline and follow-up was 9 months. So, you know, we felt comfortable that that was enough time to give, you know, to give a sense of the person engaging, the work with the case manager, and to see some impact. So now on to some of the results of this process. Across all of the measures, essentially, we found that the changes were significant. Probably the more important thing is the effect size, which gives you a measure of the magnitude of the impact. And for people who are not familiar, I've put here the small, the medium and the large, so that you get a sense of if it's a large impact, that's better. It gives you a magnitude of the impact sense. So across the personal wellbeing index, there was actually a large effect size, and it was significant. The HUDAS was similar, as you can see. Just on the personal wellbeing index, it's still nowhere near the normal range, but it's certainly heading in the right direction. And this was a medium effect for the HUDAS, for the measure of disability. And then the K10, again, was a large effect size, which is really significant, obviously, because this is a group where the potential for suicidal ideation is significant. And then the dimensions of anger. Again, a medium effect size, and again, having a positive impact for people. So we were interested in not just, did these measures have an impact positively, but we wanted to drill down into the particular questions because we were looking for all data sources that we could use, basically. So we looked at what particular aspects within these questionnaires had the smallest changes and which had the largest changes. The smallest changes, interestingly, were in their personal relationships. And this might have been because those relationships were already good, solid relationships. The HUDAS, the difficulty walking long distances. And, I think this was just because of the nature of the physical disability aspects of the group. Many of these people had significant injuries. They were either wheelchair bound, they were not able to walk anywhere near this, if at all, some of them. The K10, this one was concerning, that the least change was in that they were so sad that nothing could cheer them up. And thinking over the last 4 weeks, how angry was someone that you wanted to hit them was a very small one, as I'd said before, the change. And then, interestingly, the largest changes were in their satisfaction with their overall health. And then the HUDAS, joining community activities made the largest change. And we know that this is really important as a psychosocial benefit, particularly for this group who had been, overall, the sense was that they were very isolated, not well connected with the community. So this was a really good one to see an improvement in. And we know how important it is for people to have social connection as part of alleviating suicidal thinking and also general mental health and wellbeing. Feelings of worthlessness was also a great one to see such a strong improvement in. And getting angry with people in situations. So when they are out and about, being able to navigate social life without those incredible frustrations. So the other thing we also looked at, and I might tell you that, you know, all this data, we had to go looking, and the DVA WASP team played a huge role in actually gathering this data and presenting it to us in de-identified form. A lot of these things are just not collected. There's an assumption that DVA collects everything about veterans, but in fact they don't. Some things are improving, but there were some aspects. Take the last one, for example, time since discharge from the ADF. You'd think that, yes, they'd know every single, isn't that recorded somewhere? But no, it's not recorded for every veteran. It will be, but certainly for some of these people who've been discharged some time ago, there wasn't a clear date of discharge. So we had a lot of incomplete data around these demographic, psychosocial type variables. But we wanted to look at all these to show that it's not, you know, it's not just about the clinical, the medical, the mental health aspects. It's about all these other things that impact on people and their psychosocial well-being. We also had a whole lot of hunches that we hoped we'd actually explore to see if they rang true. Particularly things like chronic pain, for example. Are veterans with chronic pain more likely to not improve as much on wellbeing measures as veterans without chronic pain, etc., etc. Does living situation make a difference? Does gender make a difference? We had all of these things that we wanted to explore and find out so that there was a better picture of this population. So the other thing that we did as part of that process, this baseline of this particular WASP group, which is represented in the second column, the suggestion was made, what are these people, what's the nature of this group compared to the general population of veterans, and then also compared to the general population in relation to these particular variables. And this is probably the most important table in our evaluation. It gives you the most stark representation of the needs of this veteran cohort and the complexity. So, you know, astounding differences in employment status, which are understandable given the mental health and physical health challenges for this group. Chronic pain was 4 times or more than the general population. Probably the most glaring ones are the 2 bottom ones, which you'll see the history of suicidality and threat of self-harm was 4 times that of the general population and 3 times that of the general veteran population. But the most stark, of course, is the bottom one. We differentiated suicidality history from actual requiring clinical intervention, history of suicide attempts and self-harm. And this is the most astounding. So because, you know, the limits of our data, the limits of who was able to actually complete measures, the limits of, you know, the case managers doing their role, but also being part of research and collecting data as data for research, as well as delivering their clinical services, we were looking for all the good news stories that we could. So through a hand process of looking across the data, I thought it was also important to report these types of of achievements. So by the end of this period, there were 7 veterans that were now employed that hadn't been. There were 5 living alone, which may well have been a positive. They had independence. They were no longer in circumstances where they didn't want to be. They were adults. They didn't want to live with parents. They wanted independence, autonomy. But particularly, so many of them were now engaged in community that weren't previously. And 6 had family support that had none, that were very fractured relationships previously. And financial distress was also something that changed. So not statistically rigorous, but certainly worth a mention. The demographic data, those hunches that I mentioned to you before that we were following up, you know, is there a difference whether people are male, female, chronic pain, their drug use, other aspects? Across all of those 16 variables, we examined the relationships with each of those 4 outcome variables. So we tested 64 possible interactions. And what surprised us all was that there were only 4 interactions that showed any significance. And we scratched our heads for a while and we thought, what on earth is going on here? We thought the chronic pain in particular would be one that would come up. So these variables literally had no effect on whether someone was going to do better or worse in this program, was the bottom line, according to these wellbeing measures. And keeping in mind that it's only 73 of the 204, so we don't know what the story is for those others. But certainly in this group, the measures were clearly showing complexity. So we don't know whether the ones that didn't respond were more complex, the same, etc. So it's indicative that the personalised approach to care is likely a strength of the program because people were improving regardless of all of these measures, was the conclusion that we came to. And that was a good thing. They weren't any worse off because of these things, because all of these people had multiples of all of these things. It was difficult to unravel what was going on, and maybe it was just multi-complex issues altogether. And this walking alongside case management approach was absolutely just what was needed when you've got so many issues to deal with. These are I'll show you of interest, the ones that did show up as significant, and they are a bit challenging because they involve family. But what I will say very strongly is that the sample from which this analysis is based is incredibly small. So any conclusions should be taken with great caution. And, you know, perhaps these would not be found to be significant if we had a larger sample. So quite surprisingly, the family support level interacted over time to predict changes in personal wellbeing. And what we found here was the veteran with strained or no family support actually did better in the wellbeing measure for the personal wellbeing index compared to those with family support, which was certainly a surprise to us. But what it told us was that the veterans that were possibly more isolated did very well. In fact, they gained the most, perhaps, from this case management model. The next one of these 4 where we found significance was this idea of disability, that the veterans who lived with a partner at baseline reported no significant change in their disability. And maybe, you know, it was because it was what it was as far as their physical health issues were. It got me thinking, because I'm a family carer of someone with multiple physical and mental health disability. Maybe I do too good a job in my caring role. Maybe there's something to do with it, and that it made me wonder: do I hold my person back? What's going on there? We don't know the answers, and maybe if with a larger sample, these things would not be significant. The next one is also around the WHODAS, and it had put veterans with strained or no family support reported greater reductions in their disability. What I surmised from this was maybe these people were more strongly engaged with the case manager. And I certainly sensed that from the interviews that I did with veterans. Maybe that's what, you know, they were more committed to it somehow, to the engagement process itself, eventually. And then the last one is around the data. So veterans with strained or family support at baseline reported greater reductions in their anger. And I have no clear sense of why that was. So we also, as I said earlier on, we also asked that the case managers approach the family where there were family present and available to complete the wellbeing measure. And again, we only had 16 family members who completed both the baseline and follow-up measure. And you can see, given that 70 to 80 is the normative range, the families were actually struggling as well. Not so much as the veteran, but they were still well below what a normative range would be for the personal wellbeing index. We didn't find any significance in the change between pre and post for family. There just wasn't enough data. So I'll move on now to the health utilisation and cost analysis. And of course, this didn't involve Medicare and NBS, PBS. This was purely using the data from within DVA as our data process. So we did a process of looking at different time points. So we, the good thing about DVA is that each time their person uses the DVA system, there's a record. But of course, that also means that people may well have used things that were not known to the DVA system. So it's not a capture of every aspect. We looked 6 months before after, 12 months before after, 18 before after, to try and see what was going on. Again, we used linear mixed models for repeated measures to help do that process. We expressed the cost as monthly costs. Again, these things are a moving feast, and Billy, my colleague, absolutely, we decided that this was the best representation that we could do of the cost analysis process. So interestingly, there were these a whole range of different domains. So we did an overall total costs, and we also broke it down into the different areas. So this is what we found from the overall costs. And you can see the WASP right in the middle there of the graph. That was the start point of the WASP program. And then the pre-WASP and the post-WASP. So this pattern was across all of our individual types of costs. We noticed this pattern of absolutely high use of costs and then going down, some increase after the program, and then eventually tapering back down again. And what we assumed was going on was that there were absolute crisis costs all filling up here in the foreground, particularly hospital and emergency department inpatient costs, disengagement, re-engagement. So more costs was actually not necessarily a bad thing during the program. It meant that people were actually using what they should have been using and needed to support them. And then this tapering off. What it also suggested is that somewhere perhaps between the 12 and the 18-month mark of case management may be a time of looking at how veterans can be transitioned to different type of support than this intensive case management support. We found obviously that the costs did improve overall, and largely they were hospital related. So this gives you an idea of the private and the public. A lot of the public hospital utilisation costs were around crisis admission cycles for people. The increase in the private hospital costs, we made the assumption that it was because there was more planned admission and that was actually a good thing. So again, you see this up, down, up, down. Medical costs are all of those catch-alls that are related to tests, etc., screening associated with that. And again, quite an interesting picture. Pharmacy and allied health is also a really interesting one, and you can see it's quite low prior to WASP. And, you know, here, you know, this particular group were perhaps people that were not actually engaging with treatments, particularly for mental health, prior to WASP. So their use of medications was probably quite low. They were self-medicating perhaps with other things, and that certainly was borne out in the interviews with people using a lot of alcohol, other drugs, etc. And then engaging with treatments and then tapering. And again, the allied health, low engagement to higher engagement. These are the things that we, you know, that presumably DVA wants people to engage more in for their rehab, for their ongoing healthcare needs, physio, exercise physiology, etc., etc. The rehab process, again, this was a tapering process because it was being replaced by more appropriate services as time went on. And a really good one is the veteran home care. So people were actually letting services in as a result of the trust that was being built, the rapport. People were re-engaging with life again as time went on. And so they were letting other service providers in. And then community nursing, essentially, was what this cost represented. So again, you know, engagement, intensive support, and then tapering away again as people actually improved. So to give you an actual example, I've only got time for this one. So this is a pseudonym. It's not the real photo of a person from this cohort, but Chris represents a lot of what I heard. So he joined the army at 19. His mum actually helped him do the application because he had trouble with writing. At a time in his life when he's still a teenager, he's still forming his identity, etc. So, you know, an incident happens a few years later. You know, he's run over by a tank, has multiple injuries, chronic pain, etc. He's eventually discharged formally in 2019. So there's a long process that's happened. And he came into the WASP program after 2 or 3 months of deciding whether it was for him or not. And then all these issues of spending a couple of years pretty much trying to drink himself to death, being extremely isolated, having fractured relationship with mum and dad, who he had lived with initially because they're out of need, didn't have anywhere else to go, etc. And it's what he's describing about the case manager that was particularly important. And he said she just kept trying to contact me. She didn't give up on me, even though he probably abused her a few times when she first turned up. She just kept going. She had weekly contact with him, either face-to-face or definitely on the phone. She walked alongside him in all of his interactions for quite a while, building, modelling. He then was building those abilities himself as he came to know his GP, as he came to know his specialists a bit better, and they got to know him. So it was this consistent, trustworthy following through, being realistic with the person and honest. These were all things that he said were important for him. And he clearly said, I would have been dead the way I was going. His wellbeing measures all improved, and his case manager contacted me not long back and said, you know, he's now got a part-time job. He's still got his 2 days dedicated to his appointments and looking after himself. But they were incredibly proud of the effort together. So it was quite a different relationship. He's now transferred back to the rehab program because he doesn't need the WASP program. So we had the usual recommendations clearly from these results that the WASP should continue in some form similar to what it is, this intensive case management, absolutely, where someone can literally go into the house, not just on the phone, go into the house, walk out the front door with the person, was the way that it was going to actually make a difference. The wellbeing measures absolutely seem to be appropriate. They seem to cover a whole range of what was needed to be measured. But of course they need to be consistently applied and used in clinical practice by the case managers to help inform their ongoing work with people as well. And importantly that, you know, this program, a lot of the bumps were ironed out as we went along. But of course, you know, actually getting some of these gems of people who were the case managers together and the veterans, hearing more about what we can still do to improve this program was really important. As I said, there's lots of limitations. And just to finish off, this slide was given to me by DVA, and it shows you, hopefully it's a very busy slide, and I hope you can see some of it. It gives you a representation of there's many things that have informed where we've arrived at with programs like this, the journey, and this whole triage and connect, which is a central pivotal triaging process. You can see the wellbeing and support program, the orange circle in the middle there. What the clear message is that this is a very different time for DVA. People can come forward. There is a clear process. There is a real willingness to shift the culture and really address this issue of suicide. Thank you.